Hi, good evening, and welcome to everyone to this webinar on ESMO 2020 Lung Cancer Highlights, organized by Lung Cancer Europe. My name is Alfonso Aguaron, and I will be moderating today's webinar. So it is my pleasure to introduce our speaker today, Professor Sanjay Popat, who is consultant at the Thoracic Medical Oncologist at the Royal Marsden and Professor of Thoracic Oncology at the Institute of Cancer Research in London, UK. So Professor Popat, on behalf of Lung Cancer Europe, I would really like to thank you so much for your willingness to collaborate and share your knowledge with us today, especially taking into account the tightness of your agenda. So thank you very much for being with us today. So before we get started, I would like to explain the dynamics of today's session, in case this is the first time you join one of our webinars. So during the first part, Professor Popat will give a presentation on today's topic, explaining the major updates in treatment and diagnosis of lung cancer that has been presented at the European Society of Medical Oncology Congress that was held virtually due to these COVID times in late September. And this presentation will last between 30 to 40 minutes, and then we will have some time for you to ask any questions that you may have. So there are basically two ways in which you can ask your question. If you would like to make your question using your microphone, I kindly ask you to press the raise hand icon on the GoToWebinar application you just downloaded to join the session, and I will unmute you when it is your turn. In case you would prefer to send your questions in writing, just type them in the chat or in the Q&A window, and I read them to the Professor Popat at the end of the session. So being said that, and without further ado, I wish you all a very fruitful session, and I give you the floor, Professor Popat.
Thank you, Alfonso. Colleagues, good morning, good afternoon, good evening, wherever you are. It's wonderful to be here on behalf of the group and speak to you about my highlights of the ESMO 2020 meeting. These are my disclosures. So I'm going to split this webinar, first of all, by talking about topics for patients with advanced non-small cell lung cancer. So that's non-small cell lung cancer, which is metastatic. First talking about targeted treatments, then talking about immunotherapy advances, and then at the end, I'll talk about operable non-small cell lung cancer. And these really were the highlights of the meeting. And of course, I'm happy to take any questions about anything afterwards. So in terms of new data in advanced or metastatic non-small cell lung cancer, what's new for molecular targeted treatments? So the big ticket at ESMO was the CROWN trial. This is a randomized phase 3 trial presented by my colleague Benjamin Solomon, and the title is lorlatinib versus crizotinib in the first-line treatment of patients with advanced ALK-positive non-small cell lung cancer. This is a really important trial. We've known for many years that lorlatinib is highly active in patients with relapsed ALK-positive non-small cell lung cancer. It's one of the most potent drugs that we have for treating patients with brain metastases. It also is very active outside the brain, particularly in patients that have failed first-line treatments such as crizotinib or alectinib. But is it any better than crizotinib in the first-line setting? And is it the drug that we should all be thinking of? Well, this data has been highly anticipated. So this was the design of the trial. The trial took patients that had newly diagnosed metastatic ALK-positive lung cancer, were good performance status or good energy levels. They could have gone in if they had brain disease, brain metastases, but it had to have been either treated or non-symptomatic. They had no problems from their brain. And these patients were randomized to receive either lorlatinib at the standard dose of 100 milligrams once daily or crizotinib. And the investigators were looking to see whether this improved progression-free survival. So that means, does it improve time until relapse or death? Not looking to see whether it makes people live longer. So what did the trial show? Well, it showed that lorlatinib is a highly effective drug way superior than crizotinib, and it's got this thing called a hazard ratio of 0.28. And what that broadly means is its activity in delaying the time until death or relapse is markedly superior to crizotinib at 72% superior to crizotinib. Because you look at the graph, these patients with lorlatinib are doing much better. There are many more patients relapse-free and alive at a longer period of time for lorlatinib than there are for crizotinib. So markedly superior. They also looked at whether lorlatinib could reduce the time until relapse occurs within the brain, something called intracranial time to progression by blinded independent central radiology review. And indeed, they saw that lorlatinib was spectacularly superior to crizotinib, with a big difference in intracranial time to progression. Here, nearly 98% of patients are still not relapsed within the brain at the 33-month time period, compared to nearly 45% of patients with crizotinib. And that translates to a nearly 93% relative benefit for lorlatinib over crizotinib. So these are big, big differences. But the issue is, what about the side effect profile? Now, each bar here represents the magnitude of patients experiencing a side effect, and you can look at all of these different side effects. So you can see that lorlatinib causes hypercholesterolemia or hypertriglyceridemia, so abnormal cholesterol levels or triglycerides in the vast majority of patients that it's seen, together with edema or swelling or weight increase or peripheral neuropathy. That's pins and needles or tingling in the fingers or feet that patients experience. But they also experience something called cognitive effects. So just over 20% of patients get cognitive effects, and just under 20% of patients get mood effects as well. And these are of any intensity, which is the dark blue color that we're seeing. So what are my thoughts about the CROWN trial? So this is very, very impressive activity of lorlatinib over crizotinib. The thing that we're all struggling with professionally is that crizotinib is not what we tend to use now. So lorlatinib is highly superior to crizotinib, but also the same is true for brigatinib and alectinib. Undoubtedly, lorlatinib represents a first-line treatment option for our patients, and we hope that this is licensed in Europe soon, and importantly is reimbursed in patients' countries in Europe. However, because crizotinib is no longer standard of care, is lorlatinib superior to alectinib, brigatinib? And a few months ago, we had data on a new ALK inhibitor called ensartinib. And if so, which drug should we be using, and in which group of patients? Should we be using it in all patients, patients with brain disease, patients without brain disease? It's very hard because we have to look at different trials and then make what are called cross-trial comparisons. And the problem is that the populations of the different types of ALK patients that went into these different trials of alectinib, brigatinib, and ensartinib are not exactly the same. So you have to be very difficult, very, very careful in making these cross-trial comparisons. The other thing to think about is if lorlatinib is going to markedly increase the time until relapse, and then patients do relapse, what will we use on progression? Do we have any data that the other ALK inhibitors work after lorlatinib? The answer to that is no, not really. It's very sketchy at best. What are the mechanisms of resistance to lorlatinib? What's occurring in the tumors as they evolve under the selection pressure of lorlatinib to make them resistant to lorlatinib? And does that open up another susceptibility that we can treat using another tablet? Or are patients on frontline lorlatinib going to need chemotherapy next? And finally, perhaps this is one of the most important bullet points, is do the side effects of lorlatinib justify the benefits when other ALK inhibitors are available? So we don't have any head-to-head data on lorlatinib versus alectinib, or lorlatinib versus brigatinib, or lorlatinib versus ensartinib. So we have to think these all have slightly different side effect profiles, and does the side effect profile of lorlatinib justify the benefit? And there is the ongoing debate that we're currently having as professionals amongst each other, and would like to have with you as patients and patient advocates. The next study I wanted to talk about is a very important drug coming through called mobocertinib, previously known as TAK-788. Now, this is for a very specific group of patients, patients with advanced metastatic non-small cell lung cancer, but have EGFR mutation. Now, not only do they have EGFR mutation, but they have a very particular type of EGFR mutation called EGFR exon 20 insertion. So if we think about advanced non-small cell lung cancer, between 5 and 15% of our advanced non-small cell lung cancer patients have EGFR mutation. When we look at the EGFR mutation patients, the vast majority of them, about 80%, will have what are called classic or typical EGFR mutations. These are something called deletion 19 or L858R. Those patients should be treated with traditional EGFR inhibitors. About 10% of patients have something called EGFR exon 20 insertions. Now, these types of EGFR mutations are not typically sensitive to the traditional drugs we use, gefitinib, erlotinib, afatinib, dacomitinib, or osimertinib. And really, they don't benefit very well from these kinase inhibitors. We've been trying to drug EGFR exon 20 for some time and had difficulty. Now, mobocertinib is a selectively designed EGFR exon 20 inhibitor, which particularly targets the exon 20 mutations. And the key issue is how active it is. Now, we had the first semblance of activity at previous congresses, and we had an update of patients that were treated with mobocertinib. So here at the standard dose, which is being taken forward of 160 milligrams once daily, 28 patients were treated with mobocertinib. Now, in this is called a waterfall plot. Each bar represents a patient, and the bars below the line represent the magnitude of shrinkage of a tumor. So this patient's having a lot of tumor shrinkage, and this patient's not having much tumor shrinkage, and this patient, unfortunately, is having tumor growth despite the drug. So you can see that in the vast majority of patients, there is some level of tumor shrinkage with mobocertinib, which is very good. And this plot here is called a swimmer's plot, where each lane here represents how long the patient is on treatment. And you can see that the duration of treatment for the majority of patients is really quite long. The other way of looking at it is to see what proportion of patients had very good tumor shrinkage. That's called the objective response rate. And we can see that 43% of patients had a confirmed objective response, which means 43% of the patients that were enrolled in this trial had major shrinkage. That is actually quite impressive for this drug because this group would otherwise be treated with chemotherapy. More importantly, the median duration of response, so when it shrunk, it lasted for an average of nearly 14 months. Again, very, very impressive. So this is definitely a drug which is being taken forward, and there are a number of trials occurring looking at this drug taking forward. Now, the other drug which I wanted to bring to your attention is this very interesting drug called patritumumab deruxtecan, otherwise known as U3-1402. If you can't get your head around all of these very long terms, I just simply call it U3. So U3 is a very interesting drug, and this is being developed for patients with EGFR mutated non-small cell lung cancer. So not the EGFR exon 20s we were talking about before, but the common EGFR mutations, the deletion 19 and the L858R. U3 is a very interesting drug. It's an antibody, so it's a biological drug, but to it, it's linked to a toxic chemotherapy payload. And this toxic chemotherapy payload is something called deruxtecan. And what this drug does is it goes in and it binds to the cancer cells and very specifically deposits the chemotherapy in a very precise manner where the antibody is binding. Now, this is very early preliminary data. Initially, only 12 patients with EGFR mutation positive disease were treated, and then subsequently 45 patients with EGFR mutation positive disease who had had a kinase inhibitor, and then they'd relapsed, then they'd had chemo, and then they'd relapsed again. So they're quite long into their cancer journey, but they had EGFR mutant disease. they were enrolled into this trial, and 45 patients were treated. And you can see here in this waterfall plot, again, each bar representing the magnitude of shrinkage of a tumor or in that patient. You can see that the majority of patients are getting very good shrinkage. And this is much better than we would expect to see with chemotherapy, which is what we would normally be using in this situation. Of course, unfortunately, it doesn't work for all patients, and in some patients, the tumors are growing. But it does seem to be working in the vast majority of patients that we're seeing here, which is really very, very impressive results. And importantly, when the investigators genotyped or did molecular analysis on the types of tumors that patients had when they were being treated, it didn't really matter what the molecular profile was. These patients were deriving a benefit. And in some ways, that's not surprising, because what the drug is doing is depositing a small amount of chemotherapy very locally where it's needed for patients. The next other sets of drugs that I wanted just to flag up to you for EGFR mutant lung cancer is this combination, amivantamab and lazertinib, or AMI and laser, as they're sometimes talked about. Amivantamab is a very interesting antibody. It's a biological drug which binds to EGFR on the cancer cell surface. Lazertinib is a kinase inhibitor. It's a tablet which binds and switches off EGFR within the cancer cell. Lazertinib is effectively a newer version of osimertinib, or Tagrisso. It's a potent third-generation kinase inhibitor. And in the preliminary data that had previously been presented, you can see this waterfall plot where many different patients with EGFR mutant disease are benefiting from lazertinib. Similarly, in this waterfall plot, patients with resistant EGFR mutation positive disease, where they have previously had osimertinib or other EGFR kinase inhibitors, have been treated with amivantamab. Again, we see that in many patients, the waterfall plot is showing shrinkage of their tumor. Unfortunately, not in all patients, and in some patients, it's not that effective. Well, what happens when you combine both of these drugs together? So this is the Chrysalis phase 1 study, looking to see what this safety profile is and the right dose. So here, 26 patients at increasing doses of the combination of AMI and laser were treated. And these were two groups here, 45 patients who had disease which was resistant to osimertinib, and 20 patients who were newly diagnosed and untreated. And in this study, you can see that in patients who are osimertinib resistant, we're getting very good shrinkage, because these patients would normally be treated with chemotherapy. And with this combination, it's not chemotherapy, it's a biological agent together with a tablet. The response rate is 36%, but you can see that the vast majority of patients having very good shrinkage. In fact, when you look at patients who are treatment naive, who are EGFR mutation positive but don't have any treatment so far, and you give them this new combination, it's very small numbers, only 20 patients treated so far, but you can see that every single patient here has had some element of tumor shrinkage. How long will this last? We don't know. How will the side effects evolve over time? We don't know. So this is a very active combination, which we're very much looking forward to looking at how the trials are taken forward in the future. Now, I want to spend some time talking about immunotherapy, again in patients with metastatic advanced non-small cell lung cancer. So we've gone away from the oncogene addicted or alteration space. We're now focusing on immunotherapy and what it's doing to patients. So the first study I wanted to flag is a very interesting Japanese study that my colleague Dr. Sito and his colleagues in the west of Japan had reported. And this is a phase 2 trial, an early preliminary trial, looking at the immunotherapy drug atezolizumab, combining it with bevacizumab. Now, bevacizumab, otherwise known as Avastin, modifies the blood vessels within tumors to allow drugs to penetrate deeper, and changes the blood vasculature of tumors, but also importantly, it has immunomodulatory effects. It regulates the way the immune system works. So combining it with atezolizumab is a very natural thing to do. So this trial looked at patients with high PD-L1 expression. So we know that if patients have more than 50% of PD-L1 expression, they're very much likely to benefit from atezolizumab monotherapy. The question is, what about this combination? Are you getting more than you would expect from your previous experience? So in this study, patients with advanced non-small cell lung cancer who didn't have any genetic alterations and no prior treatment, so this is the first treatment that they were getting, received the combination of atezolizumab and bevacizumab. This is given intravenously until time of progression or their side effects got bad. It was a small study, only 38 patients were treated, and the investigators were looking at the response rate. They wanted to know in this group of 38 patients, what proportion had very good shrinkage. And they were expecting to see between 40 to 62% of patients having good shrinkage. So what did they find? They did in fact find that 64% of patients had very good shrinkage. So it met the primary endpoint. So it confirmed that the combination is active, in fact, more active than they were expecting, with a response rate of 64%, 64% of the group of patients having major shrinkage. And the median progression-free survival, that's the average time between starting the treatment and relapsing or dying, is 15.9 months, which is actually very good and consistent with what we would expect in this particular setting. Well, what about the side effects? If you look at the side effects of what they were reported, all of these side effects are quite typical for what we see in a group of patients that were being treated with either immunotherapy or with bevacizumab. However, one thing I wanted to highlight is that the rate of high blood pressure, hypertension, is really quite high. So 15.4% of patients getting quite significant blood pressure, requiring additional tablets to keep this under control. So I think we just need to keep an eye on this regime, and I think it's a regime which is being taken forward in a number of different trials. And indeed, the Japanese are taking this forward in a trial where they were taking, the trial is going to be called at B First, and they're going to take patients with high PD-L1 levels, 50%, with non-squamous, non-small cell lung cancer, and going to randomly allocate them to either this regime that we've just talked about, atezo and bev, or this regime plus chemotherapy, carboplatin and paclitaxel, or just the immunotherapy alone. And many people would argue that the immunotherapy alone is currently what would be regarded as standard in this setting. And so it's looking to see what this combination brings against immunotherapy alone and what the addition of chemotherapy brings to that as well. I'm going to move on with a very important update which was given. This is an update which was given by my colleague, Dr. Julie Brahma, on the Keynote 024 trial. So Keynote 024 was presented many years ago now and is the seminal trial that embedded immunotherapy as the standard treatment for patients with upfront lung cancer, non-small cell lung cancer, where the PD-L1 level or the TPS score is 50% or more. So these patients were randomized to receive either chemotherapy or pembrolizumab Keytruda monotherapy. So what happened to these patients? Well, we now have 5 years of follow-up. We've been seeing what happens to these patients. We know that pembrolizumab is superior to chemotherapy because that's now the approved indication. That's what we use where it's funded within our hospital system. What we're now seeing is that patients with immunotherapy in the green line not only do better than chemotherapy, but they're doing spectacularly better. The proportion of patients alive 5 years after starting pembrolizumab is 31%. Now, I want to put that in context because when the ISLC, International Association of Lung Cancer, recently classified what the expected proportion of patients with stage 4 lung cancer, which is what we've got here, would survive 5 years, their projections were based on historical series. that historically the proportion of patients surviving 5 years was 5%. So we've gone from 5% to using immunotherapy up front to 32%, which is a spectacular success. And I think this really does reinforce to us that we need to ensure that patients that are suitable for immunotherapy are getting immunotherapy up front. Importantly, in this trial, patients who had immunotherapy could only receive it for up to 2 years, which was the schedule of the immunotherapy. And in the trial, if patients did relapse after having discontinued at the 2-year time point, they were allowed to re-challenge. And in the study of the patients that did discontinue the immunotherapy, then did relapse, immunotherapy was again active. In a third of patients, immunotherapy resulted in very good shrinkage. In half of the patients, the tumor stayed relatively stable. It didn't shrink markedly, but it didn't grow. And in only one patient, 10% of the population, did the immunotherapy not work. So there is an opportunity to re-challenge patients with pembrolizumab. Whether that's funded or not within individual countries is a separate matter, but the data exists to support that. Now I want to change gears in the next 20 minutes, talk about patients with operable non-small cell lung cancer. This is early lung cancer, caught not before it's metastatic, but caught at which time surgery is on the cards. Or indeed, patients who've had surgery, what can we do to minimize their risk of relapse? So the first trial I wanted to talk about is the ADAURA trial. This is a really important trial, which was the focus of the ASCO meeting in June, at the beginning of June. Here, patients who'd undergone surgery for their lung cancer, but their tumors were EGFR mutation positive. So this is not all patients with resected lung cancer, but EGFR mutation positive lung cancer who'd undergone surgery. They were allowed to have chemotherapy or not if they and their doctors agreed that that was the right way forward, as per usual indications. And then were randomized to receive either osimertinib for 3 years or placebo, looking to see whether osimertinib would delay the time until relapse. We know that the trial was strongly positive because this was data presented in June, that in patients with involved nodes at the time of surgery, osimertinib was markedly superior in pushing back the time of relapse. In fact, it was 83% superior, spectacularly superior in pushing back the time of relapse. The question is, what happens to those patients in the groups that either got osimertinib or got placebo? What happened in the brain, and did it protect the relapse within the chest or other parts of the body? And indeed, when we look at the disease recurrence, we see that the disease recurrence was less in patients with osimertinib compared to placebo. And when the disease did recur, it tended to recur less outside the chest, in distant areas of the body, as you would expect from an active drug. Because the worry is that at the time of surgery, some seedlings have already spread out into the body. So osimertinib not only reduces the disease recurrence compared to placebo, but it reduces the type of distant recurrence, which is very pleasing to see because that's exactly what we'd expect. But osimertinib is also very good because it crosses into the brain. So does it protect the brain, or does it reduce the amount of brain relapse? Indeed, it does. When we look at the sites at which relapse occurred, we see that in the placebo arm, 10% of patients are relapsing in the brain, but in the osimertinib arm, only 1% of patients are relapsing within the brain. So it seems to have a protective effect. Indeed, if we look at what's called disease-free survival in the CNS, so this says look at the brain only in patients that are in this trial and see whether osimertinib prolongs the time until relapse, we can see it does markedly for patients receiving osimertinib compared to not receiving osimertinib, with a hazard ratio of 0.18, which means that's a 82% benefit. So in conclusion, Dr. Suboy, who presented, said that the risk of local and distant recurrence was improved by osimertinib, and it also improved the intracranial recurrence. So here are my comments. So this is very much an impressive reduction in the distant relapse, as would be expected for an active drug. It's also a very impressive reduction in brain relapse, and it's certainly very much hoped for and very nice to see, especially because we know that osimertinib is a CNS penetrating agent. And it certainly helps confirm the potential benefit when using this in EGFR mutation positive patients after surgery. But here's the big ifs. This data does not tell us that osimertinib improves survival, it just delays relapse. So should we be using it now to delay relapse, or are these patients destined to relapse anyway, and then we use it at the time of relapse? And there are some technical issues about this trial. The data may be biased because not all patients had ongoing brain surveillance. So you only pick up patients that become symptomatic, not patients who have brain relapse that isn't symptomatic. And so therefore the debate as to whether we use upfront or later line osimertinib continues. The next study is a very important study called the LUNGART trial. This is a very important study run in Europe to look at patients that had had lung cancer resected, but if they had lymph nodes involved, central lymph nodes involved, N2 lymph nodes involved, should they have radiotherapy or not? Now, in these patients with N2 or central lymph nodes involved, chemotherapy is usually recommended after surgery to minimize the risk of relapse. The question is, should we be using radiotherapy as well to really get on top of anything that might be left in the chest? Now, the reason that we're doing this is that we know that we shouldn't be doing it for patients without lymph nodes, and we shouldn't be doing it for patients with hilar lymph nodes, so lung lymph nodes, since data in 1998. But since then, we've never really come to a consensus for patients with central lymph nodes or N2 disease. So this trial took patients with central lymph nodes, N2 disease, and randomly allocated them to either follow-up or radiotherapy, and this is a standard regime, 54 gray in 5.5 weeks. And what did it show? Well, it was looking to see whether the relapse rate was lower with radiotherapy than not at the 3-year time point. And when we look here at the 3-year time point, the relapse rate in patients with radiotherapy is 47%, and in patients without radiotherapy, 43%. So no real difference there. So radiotherapy does not significantly improve the relapse rate at 3-year time point. It doesn't also make people live longer, and at the 3-year time point, the lifespan for patients was exactly the same. But importantly, in patients that were receiving radiotherapy, there was an excess of deaths attributable to heart and lung problems, and an excess of deaths attributable to radiotherapy or chemotherapy-related issues. So undoubtedly, adjuvant radiotherapy is more toxic than not, and is not associated with a protective effect. In fact, can increase the risk of death from other causes. So this study has answered a question oncologists have been asking for some time. Adjuvant radiotherapy does not improve disease-free survival significantly in operated patients, and there is an important risk of harm from cardiac and lung toxicities. There are, of course, many remaining questions. So are there patients that do benefit? Because there may be some patients within that overall population that do benefit, but we're not seeing them. So which patients do benefit, or should no patients have this? And which of the patients get the long-term cardiac toxicities? Because maybe it's those that we don't need to treat and others that we do need to treat. Many questions still ongoing. Finally, 2 data sets I wanted to talk about. Immunotherapy. Should we be using immunotherapy in patients that have operable disease? This has been an area of ongoing intense research in recent years, and there are multiple trials ongoing and will report over the course of the next 2 years. The first of these trials was reported a couple of years ago. That we've had at least 2 trials from the US, as well as other small trials. And this is a very important French trial performed at the Institut Gustave Roussy, just in Paris, called the PRINCEP study. This is looking to see whether patients with resectable non-small cell lung cancer, so tumors in the chest, what happens to them if we give them 1 dose of atezolizumab immunotherapy. Here's the design of the study. Patients with operable lung cancer, at least 2 centimeters large, had 1 dose of atezolizumab and then underwent surgery a month later. During that time period, they had pretty intensive monitoring with a PET scan beforehand, a PET scan at week 3, together with lots of blood work, and then their surgical specimen was intensively analysed, and they were followed up to see what happened to those patients. What we see is that the type of surgery was as expected. 93% of patients underwent a lobectomy, and 97% of patients had a complete resection. So it didn't seem to impact on the ability to perform surgery as you would expect. There were no life-threatening complications and no deaths due to the treatment, which is good to see. But there was 1 patient who had significant respiratory distress. So what happens with the immunotherapy? Well, what they showed is that although only 29% of patients were treated, 2 patients had some shrinkage, which is good to see, because these patients were not selected by PD-L1 status. Everybody had the immunotherapy. There wasn't a huge amount of change on the PET scan, but when the investigators looked at the specimen that came out, undoubtedly in many patients, there was very good activity of only a single dose of atezolizumab. In fact, in 14% of the patients, something called a major pathological response happened, which meant that when they looked at the tumor, only 10% of the tumor was still left alive, only with 1 dose of immunotherapy, and that's important. So we think that if we give immunotherapy before surgery, about 15% of patients will have a major shrinkage of their tumor at the time of resection. However, we need to be careful, because this other study, again performed in France, called the IONESCO trial, reported. So this is a very similar trial looking at a similar population of patients, and they were treated not with atezolizumab but with durvalumab, a very similar immunotherapy agent. Instead of 1 dose, 3 doses were given a fortnight apart, which is very reasonable. And they had surgery 2 weeks after the last infusion. They were followed up to see what happened. And what they found is, as per the previous Paris study, 90% of patients had a complete resection, which is good to see. So it doesn't impact on the ability of the surgeons obviously to perform the surgery. And indeed, the shrinkage rate was, as we'd seen with the French study on CT scan, about 10% of patients getting shrinkage on the CT scan. And what they find is when they look at the pathology specimen, again, we had 15% in the Paris study. Here we've got 18% of patients with very good pathological, major pathological response. It's all shrinking down beautifully. However, the study was stopped because within 90 days of surgery, there were 4 deaths. These did not, on the face of it, seem attributable to the durvalumab. 1 was a sudden death, 1 was a complication of the surgery, another one was a fistula, which you could argue is a surgical complication, and 1 is a respiratory distress, which could be for many reasons. So I think we need to be very, very mindful of the risks involved with immunotherapy before surgery. So my study with those 2 studies, that preoperative immunotherapy is very active. Around 15% of patients have what's called a major pathological response. So the tumor shrinks down with less than 10% of viable cells left. And that's much better than we would expect if we were giving chemotherapy in that setting. there's no clear relationship between immunotherapy and the benefits on scans. And that's the real challenge we have, because we can do scans and we can see preoperatively that the tumor is staying stable, and we're worried. In fact, it might even look more active on a PET scan. But when you look at that specimen under the knife, under the microscope, it could easily be lots of dead cancer cells. So that, I think, has lots of implications, because maybe in the metastatic setting, when we're looking at our scans, we're not sure what they're showing. Maybe they're showing a similar thing. We have to be very careful about the risk of death with immunotherapy, because this has been reported in other trials as well, and it's not without its risks. So with that, I would very much like to thank you for your attention. I do hope you found that of interest, and I'll hand back to our moderator for any questions if there are any.
Thank you very much, Professor Popat. I really think that it's been a very comprehensive, but at the same time, very clear presentation. And I'm pretty sure that our audience has really taken a lot of knowledge out of this. We're going to start with the Q&A session. So some of you have already some questions in writing. I remind you that you have two ways to participate. One of them is to press the raise hand icon in case you would like to make your question live by using your microphone. Or, as some of you have already said, send your questions via the chat or the Q&A window. So I'm going to go with the first question I have received, who says, do the results of the CROWN trial add clarity to the standard of care in first line for ALK patients, or this would certainly depend on physician's choice on which inhibitor drug to use based on patient characteristics?
Yeah, it's a very good question, and I think this is the question that we are asking ourselves at the moment. I think what the CROWN trial tells us is that lorlatinib is markedly superior to crizotinib. The problem is crizotinib is no longer our standard of care. Now, if you look at the metrics for progression-free survival, on paper, crizotinib is way superior to ensartinib, to brigatinib, and to alectinib, with a very low progression-free survival hazard ratio. I think you have to be a bit careful by making cross-trial comparisons, because not in each trial were exactly the same population used. And lorlatinib has, some unusual toxicities, the neurocognitive side effects, the speech problems, the mood effects, the fact that many patients need to be on a statin at the same time, can be problematic. The other problem that we have with lorlatinib is, so what are you going to use after you stop? Because we're not going to be able to sequence another ALK kinase inhibitor, because we don't really have the information that we need about mechanisms of resistance. So I think there are some oncologists undoubtedly who will say this is, by far the most superior drug. This is our new standard of care. And I think that's a very reasonable strategy. And there are other oncologists who will say, well, hang on, I'm not sure that I want to be rushing straight into this, because we don't have more mature data. We don't know the sequence of events. Is it making patients potentially live longer, which is ultimately what we want for our patients? And, how are they doing when they relapse after lorlatinib? What treatment options do we have? So there are others who are going to hold off. I think that there's going to be some debate about lorlatinib for a bit of a while.
Thank you so much, Doctor. And the next question is also related to the CROWN trial, and maybe you have responded this a little bit with your current answer, but just in case. So the person who has sent the question said, based on the impressive results in terms of progression-free survival for the CROWN results, how do you see the access scheme to this drug across Europe as a first-line treatment for ALK patients? And he also states, I assume as a relatively new drug compared to crizotinib, the impact on health budget might be significant.
The impact on?
Health budget.
Health budgets, yeah, absolutely. So to be completely honest with you, I don't know offhand the cost of lorlatinib per month, but I don't think it will be cheap. So, there will be a health impact, and this is going to be a big issue that each of our European states are going to have to think about. The drug is on track to be licensed for the first line setting. I have no doubt that it will get a first-line license by the European regulator EMA. The bigger issue is, will the countries pay for it? Now, each country has a different process for approving costs, and those processes will need to be gone through. Will the drug be made available prior to license? I think that's a question really for Pfizer, and the patient should be asking via their oncologists to Pfizer. It would be very reasonable, I think, if Pfizer would make this available, because I think it's a very active drug, and undoubtedly I think there will be patients that would want it, and undoubtedly there'll be oncologists that would want it as well. Whether Pfizer will make it available or not, I don't know, and that's very much a matter for Pfizer to decide. But undoubtedly it will have additional health budgets. But you could argue that if you're using it up front, you then don't have the additional lorlatinib use afterwards. You may not be using other ALK inhibitors afterwards. So you'd need to do the complex modeling of costs and survival that are done during what are called health technology assessment submissions.
Thank you so much, Doctor. I move on to the next question. And so it says, in your opinion, do you think that the better understanding of molecular biology and markers related to certain types of lung cancer would bring an increasing number of monoclonal antibodies like patritumab or amivantamab in the future? And to my understanding, this would potentially bring benefits to patients in terms of lesser side effects, so quality of life can be improved.
Yeah, I think this is the future. I mean, we're now in a molecular era of lung cancer. We all now practice genomic medicine. Genomic medicine is standard. Patients with non-squamous lung cancer, as per our ESMO and country guidelines, should have genotyping. And you could make an argument that patients should have at least 9 biomarkers at the time of diagnosis to make sure that all their actionable alterations are identified. The language of genomics is a really complex language that oncologists have had to learn, and it's really important that oncologists and the support staff, nurses, nurse specialists, clinical scientists have that language of genomics so they can explain this. But I do think that knowledge will expand over the course of the next few years, and that will allow us to exploit advances in new treatments such as amivantamab, lazertinib, mobocertinib, other drugs which are being evaluated, and bring these to Europe. And we'll have different side effects to chemo, because these biological agents aren't without side effects. Don't get me wrong; they just have different side effects to what we're used to with chemotherapy. But it's all pointless if patients aren't living longer or they're not deriving clinical benefit. So fundamentally, we have to do the trials that show that these patients are deriving clinical benefit from these. But undoubtedly, I think the whole field of molecular medicine will continue to expand over the course of the next few years.
Thank you so much, Doctor. So there are a couple of questions which are basically the same one, so I'm going to just go for one of them, which says, on the light of the results presented at ESMO, do you think that chemotherapy will be gradually playing a lesser important role in the treatment of lung cancer, or will it remain for a long time yet? I think he's basically...
I think in metastatic lung cancer, we've been very gradually moving towards the field that, look, you have 2 groups of disease in metastatic non-small cell lung cancer. You have the oncogene addicted disease, which has alterations like fusions and mutations, and they are treated for a period of time with biological agents, tablets or antibodies, at which point you get to a point at which they stop working. And then at that point, we're using chemotherapy. So for that group, I don't think chemo's going to disappear. We're just trying to push it away into the long grass for as long as possible. The other group of patients are patients without alterations, in whom they are principally treated with immunotherapy. And in this setting, chemotherapy has much less of a role. It does still have a role, and we're really looking at more and more combinations of new immunotherapy drugs to try and find the holy grail of a chemo-free regime. Now we have some chemo-free regimes coming through. We have pembrolizumab monotherapy, we have nivo-ipi, nivolumab-ipilimumab combination. But really, the holy grail is trying to find other newer immunomodulatory drugs coming through. And I think things like the combination of atezo with bevacizumab are really exciting in that space. But will they be suitable for all of those patients, or just the more than 50% positive patients who seem to be really immune sensitive? That's the great unknown, and there's a lot of work we still need to do in figuring out what these safe combinations are. Are they safe? Can we deliver them? Who benefits? What are the side effects? A lot of work still to be done, but yeah, I am optimistic. I do see chemo being pushed into the long grass more and more.
Hopefully, this good wishes become a reality sooner than later. So we still have a few questions left. So next one. Well, I have to say that there are many people sending thank you messages for the presentation. Many people are saying that they feel it's great. So I just wanted to pass those to you. So the next question says, with all these great results, do you think we might be talking about a certain group of patients with advanced disease who can be cured or chronified in the near future?
Whoa, that's a really
that's the question, huh?
That's a strong question. Well, I mean, we've got 30% of people who started with frontline pembrolizumab who are alive at 5 years. If you break that down further, I didn't show the data, but what the investigators showed is that if you start pembrolizumab, 20% of patients will be relapse-free at 5 years. So they started pembrolizumab, and 5 years later, they haven't relapsed. Now, we only used to follow up patients for 5 years. Will they be free? Will they be cured? I mean, who knows? I think it really does raise this as a question. Maybe they will. I mean, I've never thought I'd say that a few years ago, but I think that's a really open question now, and I'm feeling very optimistic about the future, because I think in some patients it might.
Great, thanks for that response. So next one is about the KIAN 024. So this person says the results of KIAN 024 gives a lot of hope. And there are two questions here. The first one is there a consensus in the community about patients with? Sorry, let me just read it again, because is there a consensus in the community of which patients with similar characteristics to the one in the trial should go for immunotherapy at first line? And the second question is, how does this deal with the fact that in real world practice, we're still struggling in some countries with a lack of a proper genetic testing that can be delayed for weeks or months, and some patients start treatment right away before knowing the results?
Yeah, so I mean, I think the trials basically show that if your PD-L1 level is more than 50% and you're in good performance status, then you should be having frontline immunotherapy. I totally get that in parts of the world, in parts of Europe, it's just not accessible. It's just not fundable, and that's a big problem that our patients have to face. And I feel that pain, because it's really difficult. One thing I'm optimistic of is that there are many new, very similar immunotherapies coming through. We have data presented at ESMO from Regeneron, who has a very nice PD-1 inhibitor. We have data from Beijing Pharma, who has a very nice PD-1 inhibitor. Both of those compounds are looking similarly active. Now, in open market where you have competition for price, maybe the economics will work out, where there will be many different PD-1 inhibitors coming through, which will be less costly to be able to be reimbursed by a country. So I'm actually optimistic about the availability of checkpoint inhibitors in the future. The second question you asked, Alfonso, is about patients having to wait for molecular tests. It takes a long time, and this is a big challenge even in the Western European countries, even the big centers actually, because the more testing you do, the deeper your testing becomes, the more panel you do, the longer time it takes to do. So I think the first thing is the message for oncologists. If the patient's well, don't immediately rush into treatment, because really you need to wait for the molecular profile. Don't start immunotherapy immediately until you've got the molecular result back, because if you're starting immunotherapy in an EGFR mutation positive patient, it doesn't work. More importantly, you're then going to find the patient's got EGFR mutation positivity and then give osimertinib, and you then already have a patient who's had immunotherapy and they'll develop really nasty side effects afterwards. Wait until you get the molecular profile back if you can. Of course, I appreciate that patients are sometimes, by the time they've been seeing their GP, primary care for a long time, they've been not well, they've been through the hospital system, finally they're diagnosed, they're really not well and they need urgent treatment. Well, look, then you have to treat. But, you know, we as experts, I think we have to be advocates for our patients and make sure that the system is working, because getting a tumor from one laboratory to another laboratory and then getting that report back to the third individual, who's the person that's actioning that, is actually quite a complex thing to do with different laboratories, and it doesn't work very well. And there's a lot of work to be done globally, because this is not just a problem for single countries. This is a problem globally, in the US, in the UK, in Western Europe, Eastern Europe, Asia. This is a global problem to make sure that molecular testing pathways are as efficient as they can be. And we as patient advocates have to really push hard for this.
And yeah, and I think here collaboration between all the interested parties is absolutely vital for advocating for better results in early diagnosis mainly, and also to have this systematic genetic testing in place to really speed up the times if when possible, because this is going to have a huge impact on many patients' lives. So, so there are just a couple of questions left, so I think we're going to make it on time. Indeed, there are many questions asking the same thing, which is, are there any relevant trials or studies in the landscape for small cell lung cancer patients?
Yeah, I mean, there are interesting compounds coming through. There are a group of different immunotherapy studies which are recruiting. I mean, I didn't talk about small cell in this presentation, but you know, we had updated data from 2 immunotherapy studies showing that immunotherapy plus chemotherapy is active in the metastatic setting. In patients with limited stage small cell lung cancer, there are a few studies still recruiting, and that's a big space where we don't really know. We've been treating limited stage small cell lung cancer with chemoradiotherapy for years, and the only changes has been the schedule of the radiotherapy we've done. At this ESMO, we had the report of a trial where patients were given immunotherapy or not, and in this particular trial, the immunotherapy, which is nivolumab, ipilimumab, did not improve survival. But that's probably because the doses of the immunotherapy were probably quite high and caused quite a lot of side effects, and so therefore the patients weren't on the immunotherapy for long enough to get the benefits. But there are more immunotherapy studies coming through over the next few years. They'll be reporting, and there's still multiple trials coming through. So small cell is an area where we are still very interested in, and you know, looking for patients to enroll into trials.
Thank you so much. And the last question is related to the last part of your presentation, which about radiotherapy. And there is a person asking whether, I'm sorry, my cat seems to want to take part in the conversation, so just jumped in front of me, whether SBRT, that is stereotactic body radiation therapy, can be a better option for treating lung cancer patients, in your opinion.
Yeah, so that's a sort of slightly different thing to the lung arc trial I was talking about, because that's typical external beam fractionated radiotherapy rather than focused stereotactic ablative radiotherapy. We know from lots of data that there are pretty similar results for patients with early operable disease that is treated with radiotherapy or surgery. Now, there's a big debate between surgeons and radiotherapists as to whether patients with operable disease should have radiotherapy or surgery. If the lymph nodes are involved, surgery is the best way forward. You can't really treat that effectively with radiotherapy. But if you've only got a small lump, then surgery is still, most people would say that's the best option because it's the most robust option that we've got data for. But there are increasingly stronger data for radiotherapy in that setting. But definitely people who are high-risk surgical patients where the risk of complications is very high for surgery, by far they should be having stereotactic radiotherapy. And in countries where they have that available, that has transformed the survival of patients with early lung cancer, because these patients are now able to be treated with a highly effective treatment.
Well, so thank you so much, and it seems that was the last question, so we managed to make it on time. And before I bring the session to a close, I would really like to thank you again, Professor Popat, for such a clear and comprehensive presentation, and also for your kindness and support to help us on today's webinar. Thank you very much on behalf of Lung Cancer Europe. And I would also like to thank everybody attending the webinar. And just a little reminder that the content of this webinar has been fully recorded, so it will be uploaded to our YouTube channel in the coming days. And also, I encourage you to stay updated for our future activities. I would like just to announce you that in November, we will be holding a webinar on the role of radiotherapy in the treatment of lung cancer. And in December, we'll have another one around the genetics and genetic testing in lung cancer. So you can stay updated just visiting our website or our Facebook and Twitter social media channels. And we also strongly encourage you to visit our website, the members section, so you can contact your local patient group in case you haven't done it yet. Being said that, again, Professor Popat, thank you so much for your time today. Thank you everyone for attending, and I would really wish you all a very nice evening. Thank you, and good evening to everyone.